That excellent anatomical demonstration of how parathyroid preservation has to be done. So my topic is parathyroid preservation in thyroid surgery, technological advances. Unintentional damage or removal of parathyroids has been reported in up to 22 to 30% of patients who under total thyroidectomy, and temporary hypocalcemia can happen up to 50%, 30 to 50%, and permanent hypocalcemia about 2%. And the current standard of care is based on the surgeon's experience, which in turn is based on the knowledge of the neck anatomy and embryology. So regarding parathyroid preservation, you have to understand these three things. One is the identification or localization of the parathyroid glands. The second is the preservation of the viable glands. And the third one is the preservation of the vasculature. So these three things are important. Identification by localization, viability of the gland, and the vasculature of the glands. And technological advances, the in thing is near infrared fluorescence imaging. And there again, there are two parts: near infrared autofluorescence, which can be either probe based, meaning that we use a probe, we touch the candidate tissue with the probe, and the system says whether it is parathyroid or not. Second thing is an image based, we don't touch, we show the camera, and on the screen we will be able to see the gland which is lit up because of autofluorescence. Okay, so we usually use the image based taking. I'm going to show it. And the second aspect is the contrast enhanced near infrared fluorescence, and the contrast is indocyanine, green angiography. So what is autofluorescence? Autofluorescence is the emission of light by molecules subsequent to excitation by a specific light wavelength, which is a contrast-free property inherent to certain tissues. Parathyroids have the autofluorescent properties and that emit light at 820 nanometer wavelength. After they are exposed to near infrared light at a peak fluorescence of 785 nanometer, meaning that parathyroid tissue is a biological fluorophore. Okay? And this is a machine which we use, we saw it. And the premise is that using near infrared autofluorescence, we are using it to identify and locate the parathyroid glands. Okay, and ICG, contrast enhanced near infrared autofluorescence, is to evaluate the parathyroid gland after the surgery for its perfusion and vascularity. Okay, so autofluorescence for identification and the ICG for perfusion and vascularity. With that introduction, I will go to a study which we did in Amrita: efficacy of near infrared imaging with indocyanine green injection guided total thyroidectomy versus conventional technique in preventing postoperative hypoparathyroidism. This was done as a thesis by Dr. Lakshmi Menon. The primary objective was to compare both these techniques, postoperative hypocalcemia and postoperative hypoparathyroidism on post-op day 1 in patients using thyroidectomy with this new technique versus the conventional technique. And the secondary objectives were to compare the rates of localization of parathyroid by naked eye versus NIRAF guided technique. And the third objective was to grade the parathyroid perfusion and vascularity in patients in the experimental arm. It was a prospective study, two-armed. Arm 1 was done by, the new technique was done by surgeon 1, and arm 2, the conventional techniques were done by surgeons 2 and 3. The basic assumption was that all these three surgeons were experts with more than 10 years experience. Of course, there is some amount of selection bias may happen, but this was our assumption. Inclusion: all patients undergoing total thyroidectomy, benign or malignant, with or without central or lateral neck dissection. Exclusion: pre-existing parathyroid disease, less than total thyroidectomy, and completion thyroidectomy. Sample size was 72 in each arms based on this calculation. And so this is a photograph showing the parathyroids and the lit up gland, and this is the ICG. I'll come to it in a video. So this is the demographic table. The 76 patients in the control in the experimental arm and 75 patients in the control arm, and the groups were comparable in terms of gender, thyroid status, size of the nodule less than or more than 2 centimeter, nodal status, and benign and malignancy, the pathology, and it was also comparable in terms of surgery, means total thyroidectomy versus neck. Okay, all the p-values were non-significant. So coming to the results, we looked at day 1 calcium. Okay, so the difference, when we took the whole patients, it was 21 versus 25%. The p-values were not significant. Okay, even the subgroup analysis, it was almost equal. All the p-values were not significant. So it was not causing statistically significant difference in the day 1 calcium levels. But the surprise came when we looked at the day 1 PTH. Okay, so it was 40, the whole patients 14% versus 28%. Okay, and p-value was 0.042, and it was also significant in nodules more than 2 centimeters, 7% versus 26%. Okay, 0.021, and those patients undergoing neck dissection, 14% versus 41%. Okay, and malignant patients, it was not significant, but again the difference was there, 16 versus 31%. So the probable reason for this, it was why it was not seen in the calcium and it was seen in PTH. Our inference is that the day 1 calcium may not be a good indicator of the hypoparathyroidism, and we correct the calcium immediately, so we cannot use it later to test whether the patient is going hypocalcemic. So PTH is a good indicator, and we showed the difference. Now coming to the second objective, localization of parathyroid glands, naked eye versus the NIRAF. This was done only in the experimental arm, N is equal to 76. Okay, by naked eye, these are the 4 quadrants, number of parathyroid glands identified without any confusion with the naked eye. If there was any confusion we used NIRAF. So only 34% was identified with the naked eye without any ambiguity. And when the NIRAF was used, this 34 increased to 67. Okay, but remaining 32, 67 plus 32, the remaining 32 we couldn't identify. Probably we know the parathyroid glands has, especially the inferior parathyroid glands, they may not be visualized. So that's probably the reason that we couldn't identify the 32% of the parathyroid glands. That's a localization of the parathyroid gland, naked eye versus NIRAF. Now coming to the perfusion and vascularity. So we used this grading regarding the perfusion and vascularity. Perfusion is regarding the gland. You look at the gland after giving ICG, and it can be graded into 3, 0, 1 and 2. Gray is a black gland, 1 is a gray gland, and 2 is a pearly white gland after giving ICG. Okay, this comes after the total thyroidectomy at the end of the procedure. And parathyroid vascularity is about the blood vessels, not about the gland. You watch the blood vessels whether it is lit up or not. And again it is 0, 1 and 2. 0, there is non-informative. 1 is there is a general vascular pattern visible, but no clear vascular pedicle flowing to the parathyroid gland. That is 1. And 2 is the best, where you can see a clear blood vessel going towards the parathyroid glands. So that's how it is graded, the perfusion and the vascularity. Okay, this is a little bit different. So what happened in our study? So regarding the perfusion, we saw most of the 38% had moderate perfusion at when we gave ICG. And vascularity, again, the last category was the more 50 percent of the gland, we could see a vessel going into the parathyroid gland. Okay, and our take about long-term hypocalcemia in our retrospective audit before we used this procedure, the permanent hypocalcemia rates in our hands were very low, approximately less than 2%. So there is not much utility and scope of improvement. Okay, maybe it's happening. The permanent hypoparathyroidism also may be coming down from less than from 2 to less than 2, but it is very difficult to prove statistically. We'll need very large numbers. So that's our take about long-term hypercalcemia. So here I'll go to a small video showing autofluorescence and indocyanine green angiography guided parathyroid. So this is the right superior parathyroid glands being preserved. You can see the well lit up autofluorescence gland. Here again, and then the right inferior parathyroid. These were identified with the eye and then was confirmed. Okay, right superior network. But on the left side, it was little different. It was not identified. We saw it with ICG because it was little stuck to the gland. We identified it with the ICG, and then it's being preserved on the left inferior. Okay, at the end, you can see the glands, the bed. Now you give ICG to check the perfusion and the vascularity. So you can see like ICG, the blood vessels coming up. And then you know that you have an idea of the gland where it is. See, you can see the gray gland. Here again, this is a gray gland. And maybe pedicle is going towards the gland. See this? And lastly, it will be looked on the specimen whether there was any gland on it. Now another video where I can show the pearly white appearance of parathyroid glands on ICG. That means the best out of. You can see the glands very nicely preserved, and see, you can see after giving ICG, 2 glands seen as white bulbs and the vasculature preserved. So this is the best situation. Okay, you can see it nice. This is not autofluorescence. This is ICG. Okay. Now, another point is about inadvertently removed parathyroid glands. Okay. So, autofluorescence guided parathyroid identification of inadvertently removed glands on the specimen and reimplantation. That's where this concept can be used. So, this is specimen is out, and we were checking and we noticed this tissue sitting there. Okay. And when we showed the camera, so that was a parathyroid gland. Okay. Now here is another video showing what we did. So again, that was a specimen, and you see this gland sitting, which was inadvertently removed. So we found out it, and then it was dissected off the specimen. It was sort of adherent, that's why we missed it. And then again, confirmation after partial dissection. And it's being minced. And implanted into the sternocleidomastoid muscle. So coming to the data about that, parathyroid auto-implantation, autofluorescence guided, total we had 158 patients, 76 from the study and 82 after we started it using routinely. The number of glands identified on the specimen after inadvertent removal was 10 out of 158. It's about 6.3% in our hands. Inadvertently removed glands, removed parathyroid glands on the specimen found out by this irelic is 6.3%, and those were auto-implanted. And temporary hypothyroidism happened in 5 out of these 10 patients, that is 50%. Even after implant, temporary, but there was no permanent hypoparathyroidism in any of these patients after 6 months. So that's the data about specimen retrieval. And then lastly, the utility of autofluorescence in redo thyroid surgery. We all know, where we used to say while doing the primer surgery, we put clips to identify the parathyroid glands. If at all we are going to require a redo thyroid surgery, and we can go after this particular clip and find out where it is. But nowadays we are using hundreds of clips. To catch the vessels. So the clips is not going to help us. So it's very difficult when you do a redo central compartment or thyroid bed clearance to identify the parathyroids and preserve it. And that's where we got some help from this particular technique. Autofluorescence guided identification and preservation of parathyroids in redo thyroid surgery, in thyroid bed recurrences and central compartment nodal recurrences. Here again another short video. So that is the dissected thyroid bed. You can see 2 candidate tissues, okay? And when we showed, this was slitting up, and here there is another suspected tissue that was like a node. And so again, this is being lit up, and this particular tissue on white light, it is not. This is a node, which is not, again, reconfirming there is a parathyroid gland lit up, but the node is not lit up. And therefore, the parathyroid gland was preserved. Okay, this is a fibrous bed, you have to understand, and the node was carefully taken out. And the data, we used this technique in 6 cases of recurrent redo thyroid surgeries. The number of cases where parathyroids were identified in these 6 was 3. That is 50% we could identify, in remaining 50% we couldn't identify. And number of no hypoparathyroidism in all the 3 patients. All the 3 where it was identified, but 1 out of 3 remaining 3 had a temporary hypoparathyroidism. So again, it's a small data, but still showing some benefit in redo thyroid surgery. Lastly, since it's a talk on technological advancements, parathyroids in robotic surgery. So robotic surgery, we all say it's all about scar and cosmesis. I say it's not just scar and cosmesis. It's also about preservation of parathyroids with 10 times magnifications and precision. So this is a parathyroid gland you see on robotic console, 10 times magnified in 3-dimensional view. You can see even small fibers, and you can preserve it. So that's parathyroid in robotic surgery. There's also a firefly technique in the system that can also be used, but even with vision, we can identify it in a better way. So to summarize, temporary hypoparathyroidism is a significant problem. Conventional methods rely on surgeons' experience, which in turn is based on the knowledge of anatomy of the glands and its vasculature. Near-infrared fluorescence is an emerging technique which helps in parathyroid preservation based on the parathyroid autofluorescence, and contrast-enhanced imaging with ICG to evaluate its vascularity and perfusion. Amrita study has convincingly shown its efficacy, and it is useful in identifying and re-implanting inadvertently removed glands, and also it has shown its help in redo thyroid surgery. Magnification and precision helps identify parathyroid preservation in robotic surgery. Thank you. I think, okay.
One
Can
quick
we take-
question.
Yeah, I think we thought we'll take the questions after. We have 1 minute.
One
Oh,
quick
okay, please.
So it was a very nice presentation. Thank you so much, sir. I have a query that in one slide you showed by naked eye, you were able to identify 32% of parathyroids
Correct.
with NIRF.
No,
But my question is that out of 100, if you are able to identify only 32 by naked eye, then was the surgeon's experience really matter? Because 32% is quite less amount in when you are
no,
operating
and
on thyroid.
without any ambiguity. Sometimes we say, no, so this is the parathyroid. And after 1 minute again, you said, oh, here comes another parathyroid. That was just a fat only. So convincingly, we were identified without any confusion in 30%. Okay, that's the thing. Because we were getting candidate tissue. So in that case, when we confirm, when we used IRAP to confirm, this 32 improved to 67. Further remaining 30, we couldn't identify. That's the data.
Thank you.
Yeah. Yes.
KK, sorry, it's compliment, great presentation. Just want to know, how do you follow your cases after the surgery, like syrup, PTH and calcium immediately after surgery or in the morning, or you add something when you have doubting that there is some problem?
Next day morning, calcium and PTH.
So then again, next day morning PTH many time is sometime, misleading and.
No, but
so-
this is what we do.
And what is the
that
figure? What is cutoff you take?
Cutoff it's 10 according to our lab. 10. That's what we data. PTH less than 10 we can see.
Can I